the nurses are strangers. A lot of times even the midwife or the physician that's attending you haven't met before. And giving your clothes away, and putting a gown on, and just all of the stuff they do. So even if you wear your own nightgown, there's still so many things, and it's really not a physiological undisturbed birth. You cannot have a normal physiological undisturbed birth in the hospital. It's just not possible.
Welcome to the show, ladies. Today, I have the absolute honor of interviewing Kristine Lauria, who is a midwife of more than 30 years, and she has devoted herself to helping families who choose home birth and midwifery care. She's also spent time on missions with Doctors Without Borders, where she provides healthcare in challenging settings like refugee camps, disaster areas, and conflict zones. Kristine serves as the Global Midwifery Director for Breech Without Borders. She is a clinical instructor and travels internationally teaching about physiological birth. She specializes in breech and multiples birth and has co-authored a guide to physiological breech birth. Her work has been impactful and inspiring and is soon to be seen in the documentary Allowed to Birth. And I first heard about you, Kristine, from Victoria Robinson, who I interviewed. Well, I'd heard about you before, actually, but she was the one who talked about the triplet home birth, because I said, have you ever been to a triplet home birth? And as you know, here at Pain Free Birth, we love twins, physiological, vaginal, twins, and breech. And I love talking about this topic. And I'd never, outside of that viral reel that I saw last year, and then Victoria telling me about you again, I said, I have to get this woman on the show. And so all that to say, welcome to the Pain Free Birth Show, Kristine. We are so honored to have you here.
I'm happy to be here.
So you're one of the few providers I know of that have delivered triplets vaginally. Vaginal triplet birth is almost unheard of, at least in the US, and I think in probably most developing countries. What is it that makes it so much more dangerous than, say, twin birth? Is there a reason it's so much more rare outside of just the fact that triplets are more rare to begin with?
It's interesting because when we don't see something and when we don't know it's possible, even twins and certainly breech, they don't have breech skills. It's a 50-50 chance that at least one or both of the babies, when we have twins, is going to be 50-50, really. That one is going to be
and breech. Probably close to 80-90% with triplets. I would imagine that one of them will be breech.
Yeah, it's very rare to have all three of them head down. And so that in and of itself is just really scary. And they're all operating on the what ifs. This could happen. This could happen. This could happen. Sure, those things could happen. What are the chances of those particular things? And when we really break it down, the chances of those things not happening are so much greater. And if you've had Stuart Fishbein on your show, I'm sure he talked about absolute versus relative risk, and the way he presents
I teach on this,
which is there's a 99.53% chance of you not having a fetal demise with twins if you go to 40 weeks. 99.53% chance. Are you willing to take that risk? That's a minuscule risk. When we look at it in absolute versus relative risk, like they're always looking for something wrong rather than looking.
Yeah, that's their job. That's how they're trained.
Exactly. Rather than going, you are right on target. These babies are growing good. And they can't do it. They cannot do it. And so they don't know what's possible. And so if you section for all triplets, and then of course, you're resuscitating them, they're all going to the NICU because they take them at 32 to 34 weeks.
They're coming early. They're not letting them go till 36 weeks or anything.
For some of those, with twins or triplets, sometimes they do need to come early. Sometimes there is TTTS or some growth restriction with one of the babies. We just need one of the babies to give us a problem, and that ruins it for the lot.
Let's talk about the famous Amber Johnson triplet birth video. Now, for those of you who have not seen this video yet, go to the show notes right now and watch it. It's about 8 minutes long and it is incredible. You will see a triplet home birth, which I have never seen before this video. Amber was so generous in wanting people to see this video, to know that this was possible. And Kristine, you were the only midwife that said yes after she had asked dozens of other midwives if they would attend a triplet home birth. And in this video, we see her delivering her first two babies. And then for the third baby, you did a breech extraction. Tell us about this incredible birth and how you handled that breech extraction.
So the first baby was head down. The second baby was Frank Breech, and those were both girls. They were spontaneous, a little over an hour apart. And it was the grandmother that received the babies. I asked Amber what she wanted, and she said she wanted her mother to receive her babies, and because she had been at all of her births. These were babies 7, 8, and 9 for her, and her mother had been at all of her previous births and had never received a baby. She had only had one other baby at home; the rest were in the hospital. And so I said, okay, I know that that's a goal. And I said, well, that'll be how it is. We'll make it happen. And so we did. And after about an hour after baby B was born, then when she got up to kind of get that last baby in the pelvis, he had been transverse prenatally. And so we were waiting for him to kind of make his little turn, and he was starting to turn. And as she got up to kind of, get him into the pelvis in a good position, her membranes released. And it was a big splash because, of course, there was nothing blocking the entryway, and it was just wide open, and so a lot of fluid came out, but also some blood. The one midwife grabbed the Doppler and was listening. I grabbed some sterile gloves, and I turned to that midwife and asked, what do we have? And she said 70. And I said, okay. So I had previously talked prenatally to Amber about the possibility of an extraction of, it could have been baby B or C, but in all likelihood, it would be the last one because he was transverse. And generally, with a multiples birth, if any baby is going to give you issues, it's twins, it'll be the second baby. And of course, with triplets, it could be the second or third, but more likely the third. And so we talked through that, and she understood what that would look like, and she consented to that being done when she heard about it prenatally. Then once baby B came, she was resting and nursing that baby and lying on her side. And I reminded her again that, if he doesn't make the full turn, I might have to help him a little bit manually, or we might have to do an extraction if there is any kind of distress. And she wasn't having contractions or anything at that moment. And she said, okay. Yeah. And she consented to it. She understood. So it was important to me that, again, she understood in the middle of the birth, but while she wasn't in any kind of distress, having active contractions. And so then when that actually did happen, I said, okay, Amber, we're going to do this. And she said, okay. So she knew I didn't have to take time to explain what I was doing. And so
Yes.
I could just do it quickly, because when it's needed urgently, you don't have time to go, okay, so this is what we're going to do. When an urgent thing is needed, you need to do it quickly. And it's way less scary if they understand what's going to happen. So I still talked her through it as I was doing it, which is very important. The whole rest of the room kind of went away from me, and I was just focused on Amber and the baby. And so as I'm going in, I'm telling her, I'm just trying to reach his feet. She said, okay. And you see her, I'm looking at her, I'm talking to her and kind of keeping her there, with me, so that, because it's going to be painful. We know that. And of course it can be scary. But the calmer that you stay, the better it is for, first of all, everybody in the room, not the least of which the mother. And so it's up to me to, no matter what, stay as calm as possible, because I am setting the tone. If I start to panic, everybody else is going to be
Right.
terrified. And
Right. You're the
so
expert.
I had to maintain the atmosphere in the room. And I think when you're watching that video, um, it doesn't look very pleasant what's going on, because it wasn't for either of us, and also the baby. He was still in really good condition. His heart tones have been great up until then, so he wasn't feeling that drop in heart tones. And so when I went to get his feet, he was moving them away from me, making the extraction harder. But in my but like in my heart, I was going, okay, he's still okay, so we have time for this. And so but I finally did grab a foot. I was actually able to grab both. One is enough, but I'm a little proud. I want to try to get both of them if I can. um and then I telling her, okay, go ahead and push. As I'm bringing the baby down, I'm asking her to push. So again, we're working together at this. First she's not pushing or resisting, and then she is having to push. And then I brought the baby up and did some maneuvers, and he came out very easily and spontaneously once he came through, once I got him down into the pelvis.
Yeah.
And he was great. His sisters had 9-10 APGAR scores, and his was 8-9. So he was, you know, out in a timely
Wow.
manner, and none of them needed any resuscitation, and he didn't either. And so I think it's a
Wow.
very good example of how, you know, uh, so if let's just say the grandmother had been able to receive all three babies, that he did come spontaneously, then what you would get are the naysayers or the more fearful people going, yeah, well, okay, but if there had been an emergency, what would you have done? It's okay when everything goes fine, but
Right.
well,
Right. The
well,
critics will say, you
there,
just got lucky.
they're right. And there was an emergency. It really, truly was. If I had not done what I did, and we called 911 to transport her, she lived very rurally. The response time, it was going to be slow, and the nearest hospital was a community hospital. We may well have lost that baby. And so there was no really other option. And we all knew that. She knew it, I knew it, and everybody else did as well. And so I did what needed to be done. I did it in a timely manner, and the outcome was good, and it was what we wanted. And then you saw immediately after, there was no rushing around in the room. People weren't, you know, frantic at all. We got the baby
Yeah,
out.
it was
Everybody's
very
just
calm. And I think for people who don't understand it, they might be looking at that going, why is she doing that? Why is her hand in the woman's vagina? And for those who don't know what a breech extraction is, and in this case he was transverse, it sounds like trying to move down and had to be repositioned in the birth canal, in the womb, to and you reached in, grabbed one foot, then the other, and then helped guide him out. And I love the point you're making in saying, like, this isn't like a routine protocol, even though it looks so calm. But obviously she's in pain. This is not like an easy procedure to do. This is a response to the emergency of his heart rate dropping and helping him be born before it became more serious.
exactly. And there
Yeah.
is a little, I think, a little scroll at the bottom that said breech
Yeah.
extraction due to decreased fetal heart tones or fetal distress. I made sure that
Yeah.
was in there, so people weren't like, what's going on all of a sudden now. So
Right.
that is in there. And but Amber's experience of it, and again, I hope you will have her on sometime so she can tell you from her own perspective. But I have heard her say, not only to me but on other podcasts and other things that we've done together, that her second birth, 10 oh, it's way over 10 years ago now, that was her biggest baby. She doesn't grow very big babies. Her babies are all in about the 6 pound range. And but he was the biggest, and he had a big head, and she said that birth hurt more than this extraction. If that gives you some idea of, so I'm not here to say she said it was fine and it wasn't. That she did say it wasn't that bad. I mean, she didn't like it, but she
Right.
literally said it wasn't that bad. I've experienced worse, and I was very happy
Yeah.
because I did try to be as gentle as I could be, and I have actually had a number of people who are hospital based, who work in hospitals in the birthing unit, and they have said to me that that was the gentlest extraction I've ever seen. And more than one
Mm,
person has reached out and said that to me. And that really, I don't see people do extraction. I have no idea. I can imagine. But for me, I'm never working with anybody that has any kind of anesthesia, obviously. And so I'm used to always being gentle. And I think when you come from
yeah.
a hospital perspective, if by and large the vast majority of women in hospitals have epidurals, even when you do a vaginal exam, they're really not feeling it. So you don't have to be gentle. You can go in there and kind of dig around. And I would
Yeah.
still, even if I have somebody that has anesthesia, I would still be gentle. I want to be gentle with their body and their tissue and everything,
Yeah.
and try to be respectful. So for me, that's
Respectful. Yes.
part of it. It's part of respecting the process. And I I get, for lack of a better term, get increasingly aggressive with something I need to do. Like if I have a shoulder dystocia, I'm going to start out as gently as possible and then be a little bit more, okay, this is going to take a little more than I thought and I wanted to do. But I don't immediately go in there with full force, like this is going to be the worst shoulder situation I've ever had. I start out gently and increase it so that hopefully
Hmm.
we don't have to get to maximum aggressive nature. So,
Right. Right.
so that's really
That's
important
such
to
a
me
good
too.
point. That I love that that's important too. That's such a good point. And I think what women don't, many of us don't realize is we don't see the extractions or the procedures being done in the hospitals and how aggressive and forceful and even violent truly that they can be. And then we wonder why so many women have birth trauma. Um, and they're left with that feeling. And I think their body knows and carries that trauma. But because we don't see the videos of how they deliver babies in the hospital, for the most part, they don't want you recording in there for a good reason, whether it's a cesarean and they're yanking babies out or they're potentially doing an extraction with an epidural or something else, even vaginal exams, or delivering the baby with, maneuvering and twisting and pulling and yanking on baby in just a normal vaginal birth. Some of the things I've seen in hospitals have been shocking, and we don't realize how strong and aggressive sometimes that these births can be. They're kind of shielded from us. And so to your point, I think what you did was absolutely so incredibly skilled and gentle, even though it might be shocking to watch. It was done beautifully well. I wanted to ask, how long was that extraction? Did that happen after the second baby was born?
That was just over an hour. They were all just over an hour apart. And so she rested between each baby, and she was resting for the last one and nursing. And she was on her side, so her the side of her belly was kind of pressing into the baby, and he was starting to turn a little bit. I find if you get them on their sides, they do want to come out, and they do generally reposition themselves. And I have every reason to believe that he was on his way, and he was doing, because he was at a little bit of an oblique angle, and then the membranes released. And so otherwise he probably would have come on his own. And I just said, it's been over an hour now, and like the other two, if you really want to have this baby, you're going to have to get up and get vertical and get the baby into the pelvis. And she said okay, and as she moved to get up, that there was the big splash. And so
Mm,
so yeah, she did need to rest in between the two, and I don't blame her at all. It's
yeah,
a lot.
that's no small feat delivering triplets. Did you ever get scared during that extraction that you mentioned at one point? We may need a resuscitation. What were you ever nervous or scared?
I would say, nervous. No, I just kind of didn't want to do it. I was just like, really, I've got to do this. Oh, and I've never, so I've done extractions before, but I've done them when I've been out in the field with MSF. And, or, you know, if you're in the middle of sub-Saharan Africa, it's what you need to do. You do what you need to do. I have never had to do a breech extraction in a home birth, and I attend a lot of multiples, and it's just never had to do it, and thankfully. And so this is the first time I really, needed to, and I was prepared. So I would say no, I wasn't nervous in that kind of way. I just, you know, just mildly. I wouldn't say that. I mean, I don't think I looked, I wasn't scared. I knew that I was going to get the baby out, and I had people all around me who were ready to resuscitate. I knew my job was going to be to get the baby out, and their job was going to be to prepare for resuscitation. And in fact, you know, as he's coming out, you hear me say, get ready to resuscitate, because I wasn't sure what condition he would be in. And honestly, I was very focused. It was like I had blinders on. It was me and Amber and the baby. That was the only thing while I was doing this. And the rest of them were all ready. They had suction, they had the ambu. Literally, it was right next to me. I was not aware anybody had put it there because I was focused, but that's how good the team was. And so we
Mm.
didn't need to resuscitate, but they were ready. They were ready to do whatever it is they needed to do. So in that regard, no, I didn't
So you were
really, I wasn't
prepared even for
fearful.
that.
Yes, absolutely. And also, I knew he was in good condition. I knew that prior he had great heart tones, and that with the membranes releasing, there was a dip. But then I knew when I was trying to get him out, he was still fighting me.
He
So
was, yeah,
we're
vibrant.
probably going to get a baby in good condition, but he might decide to kind of crash, pass out a little bit, and need some resuscitation in the process of being born. Breech, that was a lot. That was a lot for
Yeah.
him to go through. And so it wouldn't have been as shocking to me if we had had to give him a few breaths, but I still would have not expected that we would have all out neonatal resuscitation and need to call 911, that kind of thing. I would not have expected that at all based on the clinical picture just prior to the birth. So I
Yeah.
wasn't worried
And
about that.
and you're managing that the whole way, the whole time you're listening to heart tones. I saw 3 Dopplers and multiple midwives. How many midwives were at this birth?
Yeah, so we had, in terms of primary midwives with experience, there was me, there was the midwife that took care of Amber throughout her pregnancy, who has 40 years of experience, but no experience with multiples, even twins, and only a little breech experience. So she did not want to be the primary midwife for the birth. And then there was another midwife who had quite a bit of twin experience, and her name was Shannon, and she was great. I knew that she would be very helpful. And then we had 3 assistants, Shannon's student, and then 2 of Talitha's students. So there were
Wow.
only 6 people there, but only 3 midwives, and it was quality versus quantity. I could have filled the room up with 20 people. That would not have made me feel any better. I needed to know the people that I had there would do what needed to be done. So if a baby needed resuscitation, they would do that. And if Amber started hemorrhaging, I could manage the hemorrhage while they dealt with the resuscitation. And I didn't have to be looking over going, do you have the mask on the face? I didn't, I can only, and I'm laser focused when I'm doing something, vice versa. If I was resuscitating a baby, I can't worry. Are you getting these placentas out? Okay. I have to know they know how to get a placenta out. They know how to
Yeah.
do an IV. They know how to catheterize. They know how to give an injection. All of these things that need to be done, and they can do it without direction.
Yeah.
I didn't want to be saying, could you please take a blood pressure on her now postpartum? Like, I didn't want to have to do that and micromanage. I was the team leader and I could oversee, but everybody had their roles and they all did them, and that was what was key for me. So for me, less is
Yeah.
more, and it's the quality of the people coming, and that's really important. And
Absolutely.
they have to not bring fear, and they have to just be on board for whatever is happening. Um, so that's what's important to me for a team like this.
And you truly were prepared for anything. Like those are so many interventions that I think people assume can only really be done in a hospital, but you just listed off like, you know, 5 or 6 that you handling potential hemorrhage or handling fetal resuscitation, you're putting in catheters. I'm assuming you maybe brought pitocin for potentially giving in the postpartum, and you have a whole you know, hospital in your bag, so to speak, is what we say. That when we have critics of home birth, they don't often realize how much midwives truly do come prepared for. Knowing that the nearest hospital was about an hour away and the closest was a community hospital that might not be equipped to handle an emergency with triplets, how did you maneuver that, and how did Amber come to that decision to still ultimately have that triplet birth at home?
You know, we were all aware how rural we were, and that's why I was very clear prenatally of, if there is an emergency, we have to be able to handle this at home. We have to, it doesn't mean we can't call 911, but still 911 and then just sitting there waiting for them to come to transport her so she could go to the hospital. They wouldn't have done an extraction. They would have just done an emergency cesarean, right? So
Yeah.
that wasn't going to happen. And so she knew then that's why, she would need an extraction. And because we're not doing it routinely, we're doing it in an emergent situation. And the second most
Mm-hmm.
likely thing that would happen would be for me, even before having to resuscitate a baby, because we might have needed to resuscitate, but in all likelihood, it would have been a small resuscitation and been fine after. But it was hemorrhage. She was a grand multip at this point. She didn't really have a history of hemorrhage, but these are babies 7, 8, and 9. And so even with a singleton, baby 7, she's a grand multip. The likelihood of her uterus getting tired is pretty good. But with triplets, it's a given. And I don't think you will find anybody with any kind of experience out there that wouldn't say, oh yeah, she's probably going to bleed. And even if it's not a hemorrhage in that because her uterus was not contracting down well, it's still, when you give the placentas weighed like over 3 pounds. She had over 3 pounds of placentas, but the placental area is huge, right, for 3 placentas. And so that's the area that is bleeding. And so of course with twins you're going to see more bleeding, and with triplets you're going to see more bleeding. And
Yeah.
so it may not technically be a hemorrhage due to uterine atony, the uterus not contracting well, but it is more blood than usual. But again, their blood volume is higher than with a singleton. Nevertheless, you never know how anybody's going to handle that amount of bleeding. And we, in that kind of situation, when we can anticipate the potential for a large amount of blood being lost, then we can try to mitigate that. And so my suggestion to her was that when we get there, we put in a heparin lock, a saline lock in her arm, so that we have access to her vein if she were to need fluids, and she might be likely to need them. And in fact, she vomited through the entire time of the contractions before pushing. That's her pain response with all of her births, is vomiting. So she was very dehydrated and she really needed fluids. And we gave her some, and then we unhooked it so she didn't have to be hooked up to the line, because of course we don't want that. But it seemed reasonable, because if she did need fluids or need an IV with pitocin in it, we could give it to her quickly. And I did highly suggest a managed third stage, because I said, if we get all 3 babies out and you have this beautiful birth, and then all of a sudden you're bleeding so much that you're passing out on us, and then we have to call 911 and go in with 3 healthy babies, like, do we really want to do that? That doesn't sound like fun. But we can mitigate that the chance of that happening if we, kind of preempt it. And believe me, I am not an interventive midwife. I do not do any of these things routinely. I do them exceedingly rarely at home births. But in this case, it seemed reasonable. Now, I have not done it with other triplet mothers that I've had at home. I had one before that, and I had one after. And both of those, all of the babies were born in water. They were all water births. But with her, I felt like it was reasonable, especially given her not proximity to a higher level of care.
Yeah.
And
Yeah.
she lost about 600, which is, an average birth. We're going to see 300 or 400. So it was good. And her color was good and her lips she handled the blood loss, really well. But she was
Wow.
exhausted. She just gave birth 3 times. So there wasn't any hemorrhage. It was all good. And, I couldn't have asked for a better birth for her, I think,
Yeah.
under the
And having a
circumstances.
managed third stage, no doubt probably mitigated how much blood she
Yes.
lost, which makes complete
Yes.
sense in given all the situations and that you're
Yes.
sharing, that would be the best way to avoid like an emergency transfer or too much blood loss. Kristine, I want to hear more about some of your work overseas. Do you know like how many babies you've delivered in your career?
It's a little over 5,000 at this point, but
5,000?
that's over. I'm almost at 4 decades of doing this, so this is year 37, I think. So
Wow.
it's a lot, and a lot of them are in Afghanistan. I was working in a maternity that we were attending over 700 births a month, and so do the math. Of course, I wasn't at all 700, but I was at a lot of them because we just worked 24 hours a day. I'd go back and sleep for a little while, and then come back. I was required to be there for all breaches and multiples and anybody that was high risk if they had pre-eclampsia or eclamptic seizures or whatever. I was required to be there. So I was there quite a lot and saw at any given moment, we had 4 birthing rooms, and at any given moment you could walk through and just see a baby be born. It was very busy. So that is what accounts for the high numbers, is because of the
Wow.
high volume of those
So
places.
you've seen just about everything.
Just about everything. Yeah.
And in those settings, you don't have access to the medical care we have in the US. Did they have resources for cesarean or other interventions like that?
So it depends on some of them, yes, and some of them, no. And So if we did have access to cesarean, like in Sierra Leone, it was 3 hours away. So we would get them in an ambulance and, send them in. That was far, and on not nice roads either. So 3 hours away because it was bumpy. And that included a ferry ride, like because you had to get across the river. So it was like epic. And then in South Sudan, it was a refugee camp. It was not a brick and mortar type building. So, but we had a general surgeon there, so I could refer somebody for cesarean if I needed to. But we were expected to do everything vaginally, and we only do cesareans for maternal indications. This mother could potentially die. She could potentially bleed out because there's a placenta previa. We're not doing this vaginally. That would be a reason, but not, oh, geez, the fetal heart tones, it's category 2 or even category 3, if we don't have CTG, but, just to say, extreme fetal distress. No, we just stop listening to the baby. So it only
Wow.
for maternal indications.
What are
And I
some of the
know it
things
sounds
you've,
hard,
yeah,
but
that's a whole different reality that we are so not in
yes.
touch with here. What are some of the things you've learned serving in those dire situations?
So when I went through my apprenticeship, it was in the Amish community in rural Ohio. And and I, learned it was before I even gave birth myself. And I didn't have exposure prior to this of births. And I learned that birth was a normal, natural, physiological process that sometimes needed medical intervention. Not often, but usually if you left it alone, and it, didn't disrupt the process. It went okay most of the time. Sometimes you needed to do an intervention, and sometimes it was just a small intervention that could change the course of everything else, and then it got back on track. And sometimes it was a bigger intervention, and yeah. And so in some of these places like refugee camps um, and conflict zones and natural disasters, I've learned that birth is a normal, natural, physiological process that most of the time will, even under the most dire circumstances, with mothers and babies that are quite literally the highest risk mothers and babies in the world, because in sub-Saharan Africa they are, um, it works. Birth still works. And the less you interfere with it, the better, unless something is needed. So, honestly, with all that I've seen, all of the very scary things that I have seen, it has only reinforced my belief in physiological birth, because it's just part of nature and it works most of the time, even with complicated pregnancies and births.
Yeah.
So,
And South Sahara and Sudan, these are nations that have some of the highest maternal mortality rates in the world because of such little access and such low standards of living, the poverty, you've got women who are struggling in many ways. And I have no doubt your services have likely saved thousands of mothers and babies, having someone with your skill there. Do any of these births or mothers stick with you after attending them, or that you carry with you over the years?
oh yeah, always. There are special ones. I have a blog, and I write stories a lot of times while I'm out in the field. Particularly meaningful ones, ones that stick out to me, or something that's maybe been complicated or even a little bit traumatic, because there, you can be traumatized by birth. There's a lot going on,
Yeah.
especially in those situations. So I do have a number that stick out to me, and I have written about them, and
Mm.
so yeah, a lot of memories.
Um, what's something that you never get used to as a midwife that's seen thousands of births?
I think it is the resilience, of mothers and babies. Like, I'm just, when I'm about to go, this isn't going to happen. I don't think she can do this. And then she does, and I'm like, why did you not have faith in her? So I sometimes forget. I sometimes forget that um, that there's a lot of power behind that whole process, and there's a whole other aspect to birth that's, it's a hidden realm. And so
Hmm.
it's not all about what's, just what you can see.
Tell us more about that, because I so agree with you and believe that there's this spiritual component to childbirth that we often, I think, don't pay attention to or highlight, especially in the US, where we have so much of the medicalization of childbirth, and yet there's this deeply spiritual component to it. How do you see that in your work?
Being born is important, and we're all born somehow, some way, and of course we all die. It's the two things that we have in common, as human beings. But the birth experience for the mother is also very exceedingly important. It's for both people. And so when I hear someone saying, well, it's very selfish to want to have your baby at home just so that you can just have your candle lights and the water and soft music. You can go into the hospital and turn the lights down, and then at least you'll be safer. It's really selfish for you to want to do that. And
Yeah,
I
we hear that a
hear it a
lot.
lot. Mm-hmm. And and here is the thing, you cannot, you can have a vaginal birth in the hospital. You cannot have a normal physiological undisturbed birth in the hospital. It's just not possible. There are strangers. As soon as a stranger walks into the room, what, and they are, the nurses are strangers. And
Yeah.
a lot of times even the midwife or the physician that's attending you haven't met before. It, and giving your clothes away, and putting a gown on, and just all of the stuff they do. So even if you wear your own nightgown, there's still so many things, and it's really not a physiological undisturbed birth. And in hospitals, unless they've attended some home births, uh, they have never even seen what a physiological birth is. They think a baby being born in a taxi cab, the elevator, or in the parking lot of the hospital is like, oh my gosh, oh, thank God everything was okay. If the odds were in the favor that everything was going to be okay, and they were better off in the parking lot than in the birth room, right? So, um, like, let's
It's
just
so
be
true.
so, I mean, but I don't think, and I think that the spirituality of birth is largely lost in our culture. Um, and it's really very unfortunate, because if we just step back and we're quiet and we let the process unfold, it can really be a very beautiful experience, a nice welcoming for the baby, and a good experience for the mother. And that's not a selfish thing, because when we have a woman that's had a traumatic birth, and sometimes trauma can't be avoided, okay? Sometimes things happen in birth, and it's scary as heck for everybody in the room, not the least of which is the mother. But in general, a lot of women talk about traumatic birth in terms of just the way they were treated, and spoken to, and not because
Yes.
something traumatic happened, like a cord prolapse or fetal distress, was just her treatment, and the
Yes.
disrespect. And when a woman is traumatized during birth, it influences how she then goes on to mother that baby, and it
Yeah.
influences the way she parents, and it stays with her. And just without getting into a longer story, just an example of what birth trauma can do is when my grandmother died at the age of 83, and I went to be with her while she was dying. And on the last day of her life, she talked about how traumatic my mother's birth experience was for her. And my mother was an
Wow.
only child, and my grandmother had told me this before. It wasn't like I hadn't heard it. And oh, I have to tell you this before I die. She knows I've heard it. And but that's what she chose to talk about. I didn't ask her, I didn't prompt. She brought it up. And
Yeah.
she was still
You stayed with
processing
her
it.
all those years.
Yes, and she didn't want to have any more children because of my
Mm.
mother's birth. And she didn't have any
Yeah.
more. It wasn't that she couldn't, she didn't want any more. And so
Mm.
that I was a young midwife at that point. And as a young midwife, that made a huge impression on me, that wow, my job is really important. I need to protect mothers and babies, of course, at all costs. And so this
Mm.
is also why it's important for me to do an extraction that's as gentle as possible. Manage shoulder dystocia as gently as possible, and always communicating with the woman, and because it's going to be scary. Shoulder dystocia comes up like in an instant. The whole birth can be beautiful, and then all of a sudden, uh-oh, this does not look good. And you've had no time to prepare, and they haven't. It's just a split-second thing. And so you have to manage it in a way that, you're not terrifying everyone in the room, not the least of which is the mother. And so I think there have been times when I've resuscitated a baby for a couple that was their first baby, and did the whole resuscitation, and including some chest compressions and things. Everything was good. This was years ago. And, after the fact, we said, well, so now let's talk about the resuscitation. How was that for you? And they were like, oh, that's not what usually happens. They had never had a baby before. They didn't know that they come out and then you do some chest
And they
compressions and
cry
you
and
do it.
breathe.
Because we just did it like it was just like, and
Mm.
now we're going to wash our hands and now we put it like it was just
Yeah.
a thing. And so
Non-emergent. Like we're going to
it
do what we
was.
need to do and not panic.
Yeah.
Oh,
Yeah, and
yes.
internally, if you want, you can panic all you want internally. I always tell people, go ahead and panic internally, and sometimes I do, and I'm having these weird conversations with myself in my head while I'm doing this thing. And then I can freak out later if I need to. I can call
Yeah.
my best friend and be like, "You'll never guess what just happened, and this was just so awful." And I thought, you know, don't think that I don't do that sometimes because it does happen, but I think, you just have to learn how to manage it in front of people. And because a lot of it will be based on how we are, how they perceive we are. And if they see a calm affect, they're going to be like,
Mm-hmm.
oh, okay, everything is, this is scary. And there's a difference between something being scary and something being traumatic. And there's a fine line between the two, and it can easily dip into trauma if it's not handled
Yes.
by the care providers in the right way. And so I think that's really the
Yeah.
crux of it. We have to understand that even when something traumatic comes up, an emergency comes up that we're not um, creating, it's just an emergency, the way in which we deal with it makes a huge difference. And then afterwards, that person can say, that was really scary. I was really scared. I'm so glad that you talked to me, or I'm so glad you said this or that, because that's going to be the difference between that person being traumatized and that person
Yes.
just being scared, because sometimes we can't,
Yeah.
some things are going to be scary.
Yeah, and there's emergencies that happen in childbirth. There are times when intervention truly is needed. I love that differentiation that you said. It's not something we created, because truly most of the emergencies, quote unquote, we see in the hospitals are created by how women are treated, by disrupting the physiological process, by interventions that happen before that emergency. And yet there are births, to your point, where truly emergencies do happen. I've probably never interviewed anyone that has delivered as many babies and seen as many physiological births. What percentage of birth would you say, in your opinion, truly need medical intervention in a physiological birth?
Just so few. I mean, it's going to be a little higher when we get into breaches and multiples, but if we lump them all together, you know, Mm. I mean, usually it's going to be less than 5%. When I was attending births, as a community midwife, because I don't have my own private practice anymore. But my cesarean section rate was, it was about 3%. And yes, of course, I have healthy women coming to me. And so hospitals can say, yes, but you're dealing with only healthy women. Yeah, but healthy women also can have complicated births sometimes. So and have to have cesareans. But this is, it's not a very high
That's
rate,
very
you
low.
know.
Even if you were
Yeah.
to compare that to the hospital low risk population, they would never touch that. They would still see cesarean rates probably over 20%. I mean, it's 30% on average in this country, for those who don't know. And even when they've done studies comparing low risk populations to, say, home birth, they still see dramatically lower rates in home birth. And a 3% cesarean rate is unheard of. Like that's phenomenal. But what a testimony to me, that just speaks of how equipped our bodies truly are to birth when we don't disrupt the physiological process. And it's a good reminder that yes, some things can go wrong that we didn't prepare for. We may need medical intervention, and it's completely okay to get that and to accept medical intervention when it is needed, or if you just choose to.
And and I will qualify that also by saying, I'm not also then leaving in my wake a bunch of dead and damaged babies or mothers just because my
Yeah.
cesarean section rate is low. Well, it's low, but at what cost? As an example,
Yeah.
in South Sudan, we were a referral center for all of the high risk people they would fly women to me that were very high risk. And one month I had 6 cesareans for placenta previa because I had 4 of them flown into me, and then 2 of them were just from the camp that I was in. And so it was huge.
Wow.
So it really put up my cesarean overall for that 6 months. It really made my cesarean rate elevate there with these very high, because we only dealt with high risk people. You couldn't just be coming in to push out a baby. You had to have preeclampsia or polyhydramnios or multiples or breaches, or this was what we were dealing with only.
Wow.
And so
You're
nearly
dealing
6
with
years,
high risk pregnancies.
high risk. And my cesarean section rate was 4.4% for that.
4.4 when you're only dealing with high risk pregnancies?
And, and, and premature babies. And so I'm not going to count a 28-week baby that, even if it is born alive and doesn't survive, because we don't have a NICU, I'm not going to count that as a bad outcome, because we don't expect a 28-week baby in a refugee camp to survive. It's not going to happen. But by and large, it doesn't mean that I was losing mothers. I didn't lose any mothers to anything that could be prevented with cesarean section. I had 6 maternal deaths, and they were 5. No, I think 5, and they were complications of nothing with birth. They were with hepatitis E, and that E is in Edward, and people are going to go, hepatitis E, I've never heard of it. Yeah, it exists, and it's deadly in the 2nd and 3rd trimester of pregnancy for about 40% of the population. Wow. That and then a pregnancy with she was preterm, but she had AIDS, malaria, and COVID. She just wasn't going to survive. And so those were the maternal deaths I saw. It wasn't somebody hemorrhaging. It wasn't somebody with an infection. Nothing that we usually would see in those contexts. So when I say it's a 4.4%, and the only reason it was that high was because they flew those placenta previas into me. And I'm like, oh, if they hadn't done it, it could have been about 3%. So we were doing everything vaginally. We had triplets, we had twins, and all the breeches, and they were all done vaginally.
Oh
and
my gosh. That's it. I'm having a hard time even comprehending this. Like, I can't imagine what a doctor in a hospital listening to this might say. And I'm so excited for your documentary coming out. They don't know what to do with you. but the numbers don't lie. Like, they can say whatever they want and attack you, and this is dangerous, and moms are selfish for birthing at home, and you're so irresponsible to deliver triplets at home or whatever. But the numbers don't lie. Your rates, even on a high risk population, blow anything out of the water in the US. Like, find me a hospital with a 4.4% cesarean rate. You won't find it. Like, this is incredible. And we need these skills. We need midwives like you in America. And it's making like all the puzzle pieces are coming together for me in how you could take a home birth triplet delivery an hour away from a hospital and feel completely confident after everything you've seen and everything you believe about birth. Like, it's like, well, of course, this is nothing compared to the South Sudan and what you've had to maneuver there. Like, it just,
I would say that 10 years ago, I likely wouldn't have. And 10 years ago, I don't think I would have been willing to do a breech extraction. I will say that. Like, it's not like I've always done this. I have, there are acquired skills, and I feel confident in myself. But the other part of it is, who is this mother? Who are these babies? I need to know that they are going to show up for this birth just like I am, and they are committed and they understand. And that is the key there with triplets. I have a lot of people reach out to me, actually, in other parts of the world even. And I've had people reach out and say, oh, I have triplets and I'm going to, and I can tell right away it's not somebody that I would work with. I can tell just by, the first paragraph. And I'm sure they're lovely. I certainly give them advice and referrals to whomever. but most of the time it's either due to assisted reproduction, which I won't help with multiples with assisted reproduction, and or it's just somebody who I don't want. They want to give me a cesarean in the hospital, and I don't want a cesarean, so I'm going to stay home and have my babies. Not if the plan wasn't with a singleton you were going to stay home. If it's just to avoid the hospital and cesarean, that is a terrible reason to stay home. It's a really terrible with triplets. That's not somebody who's committed. The people that I've helped have had home births before. They know the responsibility of home birth, and that they know, then they're there and they're showing up for it. And so that is the most important part of it. And then we go with all the other things. Who are, how is their health profile, and how are these babies growing? And they've got to make it to 35 to 36 weeks. And most of them do. They go 38 and 39 weeks. I've had triplets go. Yeah. Amber's went to 38 and 2. And the other one, Michelle, hers went to 39 and 2. And then the other mom, 36.
Yeah. My heart goes out to those moms. Yeah. That's amazing. And what you're talking about isn't only true for triplet birth, although much more so important, that the mother's mindset has to be rock solid and committed to this birth. I completely agree and can understand that. But I think that's also true for twins, for any mother choosing home birth, for any mother choosing to birth outside the system, because there is so much of a different, there's so many people that want you to do things according to protocol, according to the status quo, according to, I want you to do it this way because if you don't, I'm liable, or something dangerous could happen. And you really have to know your values and know what you want and the kind of birth you want in order to stand your ground and commit to you and your baby, and giving your baby a different kind of experience, in starting your motherhood journey a different kind of way. And home birth is not for everyone. And I tell people this, like, I'm not here to tell you anything about how you should birth or where you should birth. It really is for the women who desire and are committed to that kind of birth experience. And even more so if you're pregnant with twins or triplets. I wanted to ask you this earlier, but I'm going to ask it now and throw it in while we're back on the triplet thing.
With triplets, it's much more likely that these babies are going to come a little bit early, spontaneously, a little bit higher that risk that you have 3 babies, so one of them might not be growing as well, and we might need to intervene, in which case that would rule them out for home birth for that, and even for vaginal birth probably. But it's not a given, and that's not been my experience with the triplets that I've assisted with. And it's only been 10 to date, and most of 11. 7 of them were in the field, and 4 of them were in the U.S. So,
wow. Tell me, this is one of my pet peeves. I'm sure you'll probably agree, but when women go into the hospital birthing twins, their doctor that's not trained in breech will say, well, we can do it, vaginal, but if that second baby is breech, then mother goes through a vaginal birth, all of the work involved in that, and then, baby B flips butt down or whatever, and they have to do an emergency cesarean because that doctor doesn't know how to do a breech extraction. There's nothing that, well, there's a lot of things that irk me, but that is one of the things that I just bang my head against a wall. And I'm sure you must feel the same, having heard probably some of those stories.
Yeah, it's not uncommon. And but my bigger pet peeve is just somebody getting to 38 weeks, their singleton is breech, and their only option is a cesarean. And I just want to say to anybody that's been to medical school and now is attending women in birth, whether it's a general practice doctor, family practice, or an obstetrician, how do you feel about having paid hundreds of thousands of dollars to get through your schooling, and you can't do a basic requirement of your job, which is to attend a birth vaginally, just because it's coming in a different presentation other than vertex? 3 to 4% of babies will be breech. And so you're quite literally failing 3 to 4% of mothers. You're giving primips a primary scar now that they have to carry for their life. Some of them are women who want to have large families, and now you have
Yeah.
doomed her to all these VBACs or all these other cesarean, because we know they get to the second
Yes.
baby. Oh, you
And
can have a VBAC. You can
increase
have a
her
VBAC.
risk.
And then, yeah, but then at 38 weeks, there's the bait and switch, and she doesn't have a VBAC.
Yeah.
And then guess what she does? For the third baby, she goes in to find a home birth midwife. And then guess what happens? The hospital's angry because you've had 2 cesareans and you're having your baby home. Yeah, because you couldn't give me a vaginal birth in the hospital. And they wanna blame midwives and home birthers for why would you do something so dangerous? Because you won't do it in the hospital. I can't have a vaginal VBAC, in the hospital. I can't have a vaginal breech in the hospital. It's not possible. They
Yes.
will do a bait and switch. And so, it's in
Oh, I
response to
love the
that.
call out, Kristen. It's so true.
And it's true. And I have friends who are obstetricians who all they do is nod and they go, yeah, you're absolutely right. You're absolutely right.
Yeah.
We didn't learn that. And there are obstetricians that I teach all the time because I teach breech all over the world. And they come up to me during the break. And they're very receptive, and they know, and they listen to me. And the reason is because they know that I have more experience than they do. I have zero surgical
Mhm.
experience. I can't do surgery to save my life. I'm not a surgeon.
Yeah.
They're way more experienced at that than I am. But normal physiological birth and breech birth, 100% multiples,
Yeah.
100%. I have more experience than they
Yeah.
do. And what a shame, because
Absolutely.
they have way more opportunities to attend those things than I do. And they're doing it in the
Yes.
environment that everybody claims to be so safe. So you have all these things, at your beck and call. So learn how to do breech. There is no excuse anymore. Breech Without Borders
Yeah.
is out there. You make a phone call, you send an email, you'll get a breech trainer.
Yep. Set up a training. What would you say to moms who are facing pushback, whether it's twins, breech, or really anything that marks them, as a potential high risk? Obviously, everything is a unique situation, but how would you encourage moms who truly believe like they want a home birth or birth, physiological birth? What words of advice would you give them to navigate this pregnancy?
I would say to research good. Don't just Google, because anybody can put out anything. Debbie Dula in her basement could write, statistically, and then there's nothing to back it up. We want good evidence-based information. So find the sites, and not the biased information, because yeah, you can go to ACOG. So your doctor can give you a pamphlet from ACOG, American College of Obstetricians and Gynecologists. It's going to be very biased. Okay. I'm just telling you that right now. And they're going to, present scary statistics. And it's just very biased in that regard. And, and not that midwives can't be biased. Absolutely. We can't. I disclose my biases to people. So, obviously I'm a home birth midwife. I'm a home birth mom. I have that bias. But I don't think that people shouldn't have their babies in the hospital. Whatever, if you want to go in for a planned cesarean section for whatever the reason is you want it, I 100% support you, because I support autonomy. This is all I'm saying, is that we should have all the choices. And so I would say, really research what your options are, research what your situation is, and talk to different people, and talk to people that truly have experience in that, whether those are parents who have gone through the experience, get that perspective always, but also different practitioners. Even if I have people who consult me, and they have zero intention of having me at their birth, either because it's, I'm not available, or, they're farther away, or whatever reason, or maybe they don't even want a home birth, but they're calling me and consulting with me because I have a different perspective than they're going to get from their current provider, whether that's a midwife or a physician. And they're going to get it based on my experience. And I'm going to tell them what if I'm telling them statistics, I'm going to show them where those come from. And if I'm saying my experience is, then I'm very clear that this is my experience. That doesn't mean it will be theirs or the next person's. And so, and I like to let people know what what is possible. Yes, it is possible to have triplets vaginally. Absolutely. Does it work for everyone? No, not everybody is going to be. The chances of you having a cesarean section is much greater than if you're just carrying one baby. We know that. It's probably,
Mm-hmm.
chances are that it's going to go sooner. And same thing with twins. But even, even twins, it's very likely that you can go to term and go into labor spontaneously and birth your babies vaginally just fine. It's about the skill level of the provider. Most of the scary things that happen with multiples happen during the prenatal period, the preterm labor, preeclampsia, that then those necessitate us to take action. But by and large, most women who are healthy going into the pregnancy are going to remain healthy, especially if they have good dietary guidance or are eating good whole food diets. And that's the single most important thing, I think, with multiples, is enough calories and protein. Really, it's like a full-time job eating at that point. So yeah, I mean, just research, ask, call people. Who is the expert on that? You can get a consultation with Stuart Fishbein. He'll tell you the truth. You send him your
Yeah.
ultrasound and say, they told me this, and he's going to look at it and go, yeah, I kind of see what they're saying, but what they're telling you is misleading because, and what is really here is this. So he's
Yeah.
going to tell you the truth. And there are other
Yeah.
physicians out here, and I refer people to MFMs and say, this is out of my scope. My opinion is this, but this is not my area of expertise. And I would rather you talk to this person who is going to tell you what their experience is. And then they consult that MFM who gives them good information. So there are
Yeah.
people that will talk to you, some for a fee and some for not. And the fee is usually pretty reasonable. And it's usually really worth it if you're really trying to avoid unnecessary interventions or cesareans or whatever.
Mm-hmm. Yeah. Yes, absolutely. Kristine, are you still practicing today? And how can women find out more information about you?
I don't have my own practice anymore, mostly because I'm traveling and teaching a lot. And so that doesn't work when you have due dates. However, I just attended a birth on Monday. It was a breech birth, unplanned by me, a midwife nearby. And she's like, I'm 30 minutes from you. And I'm at this breech birth. It's a VBAC after 2 cesareans and 2 vaginal births. So it's interesting. And so I said, yeah, I was 30 minutes away. I'm like, sure, why not? A daytime birth? Yeah, I don't even have to.
That's a lucky draw.
Twice if you call me at 3 a.m. Like, oh, can't we just Zoom? Because I do Zoom a lot of birth. I do attend a lot of Zoom births with midwives, helping them with breeches and multiples. So that's part of what I do
Wow.
because they're far away and I can't get, I can't get there. This one I could
Yeah.
get there.
Yeah.
If you think I can make it, I'll
Wow.
come. So I did. So I'm in the Upper Peninsula of Michigan, and so I'm licensed in Michigan and Wisconsin. But so I will attend births in those places if I'm nearby. And sometimes when I'm traveling, I've attended births just because they've happened to happen when I was there, and the midwife called me and I came. So it depends. In triplets, yes, I travel for triplets. They don't happen very often, but I have traveled for them. And so that's really what I do, breaches and multiples. If you have just a singleton head down baby, I'm probably not going to be there. And my friends like to make fun of me for that. But I have some exceptions. I do have some friends who I'm helping that have had
Oh.
at this point head down babies, so and so I'm helping them. But otherwise, yeah, I don't just routinely attend births. When I'm in the field though with MSF, then yes, a lot. And with Doctors Without Borders, I attend a lot of births then.
So find you on the field or find her on Instagram at Global Midwife 64. And
Yes,
Allowed to Birth is the one to follow for the documentary being made about you, which I am so excited to see. When is that being released?
it'll be 2026. Jacinta is still following me around places, so she's still, it's still in the process. And
In the process.
so
Awesome.
but yeah, and so if you follow Allowed to Birth on Instagram, you will be able to see little clips of her following me around. She makes it very entertaining. She's exceedingly creative and gifted, and I'm so impressed with her work. And
Yeah.
people are always like, "How's the documentary going?" I'm like, "I have no idea. I'm just here." And and she just comes with me sometimes, and half the time I don't even know she's filming. And now she bought a drone, so now it's even worse. So but she puts
Oh,
out some
wow.
really funny things but also heartwarming, also touching. So it's really lovely. And she is a professional birth photographer and videographer, and she has won awards for her videos and photography
Mm,
in birth. So her
yeah.
site also is very lovely with her births. You can see
Amazing.
some lovely things there.
Well, Kristine, I could talk to you all day, and we've certainly gone over the normal time, but it was so valuable, your insights and just the perspective you carry, especially your experience delivering as many births as you've attended and all over the world. What a true gem you are to mothers and the maternity and the midwifery community. And I just thank you immensely. I can't express with words how special it was to have you on the show. And I just pray that your message would go far and wide, and that the people impacted by your work would live on far beyond your years here with us, and just impact generations, because you truly are a gift. So thank you
That's my
for
hope.
coming.
That's my hope. That's why I'm teaching, because it needs to be passed on. I'm one person. I can't be everywhere. And it's not rocket science. It can be done. It can be done. It's about learning and understanding and going forward and doing it.
Mm, so true. It's not rocket science. It's simple, just learning. I love that. And with that, we'll wrap up, and thank you guys for listening. We will see you next week. If this episode has impacted you, please rate and leave a 5-star review, and please reach out to Kristine and share with her how her work has impacted you. And we will see you next week.